Hello, good morning friends. I'm Dr. Lalkrishna and today we'll be discussing about hepatocellular carcinoma. So hepatocellular carcinoma is the fifth most common malignancy in the world and second most common malignancy causing death in the world. It is the most common malignancy, so it accounts 75% of the primary hepatic neoplasm malignancies, and it is the most common site for malignancy from the GIT. So before going ahead, I would like to discuss what all things we are going to see today. So we'll be seeing the risk factors, the protective factors, pathogenesis, gross types, pathology, paraneoplastic syndromes, imaging features, staging and staging systems, and the management. So let's get started. So what are the risk factors? We'll classify risk factors into three, that is the factors causing cirrhosis and then hepatocellular carcinoma, the metabolic factors or diseases to be precise, and the environmental factors. So what are the मिठू आवाज बंद कर दे. So we'll go ahead with risk factors. So what are the risk factors primarily causing cirrhosis? That will be hepatitis B and hepatitis C, which account for 75 to 80% of these cases. To be more common, it is hepatitis B, which causes 50 to 55% of HCC. And here we have to see that cirrhosis need not precede HCC. That means जरूरी नहीं है कि cirrhosis होगा HCC से पहले, जरूरी नहीं है, हो भी सकता है, ठीक है. Mark my words. Hepatitis C accounts for 25 to 30% cases, but here cirrhosis will always precede HCC. That means cirrhosis होगा, उसके बाद HCC होगा. Then we come to environmental factors which can be modifiable, like alcohol, smoking, aflatoxin exposure. Aflatoxin causes mycotoxin. Mycotoxin in aflatoxin causes p53 mutation, which is a genetic correlation. Then vinyl chloride exposure, as in the industries, OC pill use, diabetes, non-alcoholic steatohepatitis, and some metabolic congenital disorders like hereditary hemochromatosis, alpha-1 antitrypsin, and Wilson's disease. So these are the risk factors. What are the protective factors? These are statins, that is a hypolipidemic drug, and vaccination against hepatitis B. What is the pathogenesis? Multi-step regression. So there will be dysplastic nodules, nodular size more than 5 mm, which will result in early HCC, which will follow the path of well differentiated HCC to moderate differentiated HCC and then poorly differentiated HCC. And initially it will be low grade and it will progress to high grade. So increased dependency on hepatic arterial and neoarterial supply. It goes on increasing from low grade to high grade and early HCC to poorly differentiated HCC. Now we'll be seeing the gross types. So what are the gross types? These are the nodular type, where there is no extranodal extension, no multinodularity. Massive type, where it is in liver without cirrhosis and has increased chances of spread, and diffuse multiple small lesion, which has highest chance of spread. Then we see the fibrolamellar variant is there, and a combined HCC and cholangiocarcinoma. So what are the paraneoplastic syndromes associated with HCC? It is hypoglycemia, hypercalcemia, watery diarrhea, hypercholesterolemia, erythrocytosis, thrombocytopenia, cutaneous manifestation in the form of sebaceous keratosis, pityriasis rotunda, dermatomyositis, pemphigus, foliaceous, and porphyria cutanea tada. Now we'll go ahead with the imaging features. So these are hypervascular tumor, and The initial investigation of choice will be the initial investigation rather will be ultrasound, and which it will be investigation of choice will be CECT, triple contrast CT scan, triple phase contrast CT scan, and we will have a arterial phase enhancement, that the tumor will appear hyper dense, and followed by it will having venous washout in the portal and venous phase. So then it will be hypodense, and in comparison to metastasis from any other tumor, primary tumor, it will be hypodense. The arterial phase will not be enhanced and it will be hypodense. We have to avoid FNAC. If we are contemplating liver transplantation, we have to try not to take biopsy नहीं लेना है, क्योंकि उससे spread होने का risk रहेगा, risk of peritoneal seeding. In case of difficulty, we can think about it, but it will always be controversial. Then we will see something about the tumor markers. So tumor markers, these are AFP, which will be increased more than 20 milligram per ml, seen in 70% of HCC. Alpha fetoprotein is non-specific but is useful for recurrence and follow-up. Then we have PEVKA2, that is protein-induced vitamin K antagonism, also known as des-gamma carboxyprothrombin, and it is increased in HCC. Then we have glycipan, HEPAR, and neurotensin B, which is raised especially in the fibrolamellar variant. Then we'll go ahead with the clinical features. Clinical features, the most common being abdominal pain followed by weight loss, and weight loss should be significant, but we have to consider even if it is not significant, if it is more than 5% of weight loss in 1 month, or more than 10% weight loss in 6 months, or 20% weight loss in 1 year. What are the other symptoms which will help us in diagnosis? Will be anorexia, fatigue, jaundice, which is seen in the 10% cases, tumor rupture in 3 to 5% cases, possibility of audible brew in 20 to 25% cases, hypercholesterolemia, which will be most common, hypoglycemia, which will be second most common, paraneoplastic syndrome. We have seen the other. Then we'll go ahead with the staging system. So in the staging, we have TNM, and here we have to consider the liver tumor size along with the patient status and the liver status. So what is the AGCC, which is not very useful, but still we'll have a look at it because we see it in the GI tract. It will help us remember and understand better. So tumor TNM staging, T1 will be less than 2 centimeter with or without vascular invasion, more than 2 centimeter without vascular invasion. T2 will be 2 to 5 centimeter. It will be solitary or multiple, none greater than 5 centimeter, and possibility of vascular invasion in case it is 2 to 5 centimeter. T3 more than 5 centimeter, solitary or multiple. T4 involvement of major branch of portal vein, hepatic vein, or direct invasion to the adjacent organs. N is surrounding lymph node metastasis, and M1 is distant metastasis. Grades are 4: well differentiated, moderately, poorly, and undifferentiated. 1 to 4. 1 is well differentiated, 2 is moderately differentiated, 3 is poorly differentiated, and 4 is undifferentiated. Then we come to staging, where stage 1 is T1, stage 2 is T2, rest is N0, M0. Stage 3A is T3, N0, M0, and stage 3B is T4, N0, M0. Stage 4A where there is N1, and stage 4B is when there is M1. Then we see the Okuda staging system, where we have TAAB. TAAB, tumor size, ascites, albumin, bilirubin. So if the tumor size involves more than 50% of liver, it is positive. If there is clinical ascites, then it is positive. If there is more than 3 bilirubin, rather first we'll consider albumin, less than 3 gram per deciliter albumin, then it is positive, and more, sorry, less than 3 gram per deciliter is albumin is positive, and bilirubin more than 3 milligram per deciliter is positive. So these are the 4 points, criterias which are involved in the Okuda staging system, and it will help us in managing our patients. So it will further give us the stage 1 when none of the above is positive, stage 2 where 1 or 2 criteria above are positive, stage 3 where 3 or 4 criteria are positive. We have other scoring system like cancer liver Italian program that involves CTAP, that is CTP score ABC, where it will be A will be 0, B will be 1, C will be 2, tumor morphology uninodular with extension less than 50% will be 0, multinodular extension less than 50% 1, massive with extension more than 50% 2, AFP less than 400 nanogram per ml 0, more than 400 nanogram per ml 1, portal vein thrombosis present and absent will give us 0 or 1 point. So we'll use Barcelona Clinic liver cancer algorithm for treatment, where we'll go ahead with resection in child pug A with indication less than 5 centimeter, nodules none more than 3 nodules, none more than 3 centimeter, no portal, hypertension. And we use Milan's criteria for orthoptic liver transplantation in hepatocellular carcinoma. So before going ahead, we would discuss about the management. It would be better if we discuss what are the modalities which we have for management first, and then we go ahead with what are the management modalities we have for HCC. That is treatment option for liver cancer, that is first and foremost, which is curative, is the hepatic resection. When the hepatic reserve is adequate, if we have less hepatic reserve, we'll go ahead with resection and transplantation. Then we have ablative techniques with help of radiofrequency ablation, others like ethanol ablation, cryoablation, microwave ablation, regional liver therapies in the form of chemoembolization or embolization, hepatic artery pump chemoperfusion, internal radiation therapy with help of yttrium 90 internal radiation, external beam radiation therapy in the form of stereotactic radiosurgery, cyberknife, triology, or synergy, intensity modulated radiation therapy, that is IMRT, then systemic chemotherapy and multimodality approach. So these are all the treatment options available, and most of the time we have multimodality approach which is the best for the patient, and it has to be taken after a well discussion with the management team on the liver tumor board. So once the HCC is identified, we'll see if the patient is a resection candidate, whether the patient is having adequate liver reserve more than 25-30%. If it is yes, we consider it, especially in the non-cirrhotic child A with single lesion and no metastasis. Then we consider transplantation in cases where lesion is single less than 5 centimeter, more than 3 lesion less than equal to 3 centimeter, child A, B, C, all will be fine, no gross vascular invasion, no metastasis. So if we have suitable donor, then we can consider live donor liver transplant. Otherwise, we can consider cadaveric liver transplant. If that is not possible or it is not feasible, we may have to go ahead with neoadjuvant therapy in the form of radiofrequency ablation or chemoembolization, then followed by orthoptic liver transplantation. If the MELD score is more than 3, then we have to consider about the neoadjuvant therapy before going for the transplantation. If the patient cannot be transplanted, then we have to go for palliation due to comorbid factors, more lesions number than 4, gross vascular invasion, lymph node or distant metastasis. The primary drug will be sorafenib. Then we'll go ahead if needed, then we can go ahead with percutaneous or lap radiofrequency ablation for case of single lesion less than 5 centimeter, child A or B, but we need clinical trials on this, and if they are going, then we have chemoembolization, that is TACE, transarterial chemoembolization. Then we have yttrium, internal radiotherapy for multifocal more than 5 centimeter, child ABC, bilirubin less than 3. Then we have new agents, that is the palliative care for patients with child C and bilirubin more than 3. So these are the some aspect of HCC treatment. We'll see in detail the principles of HCC resection in a later session. And before switching off, I would like to discuss the whole topic in short in a minute. So HCC is the 5th most common malignancy in the world, and risk factors being hepatitis B, C, alcohol, smoking, and OCP, vinyl chloride, aflatoxin, which are the environmental factors, and some metabolic factors like hereditary hemochromatosis, alpha-1 antitrypsin, Wilson's disease. Protective factors will be statin, vaccination. Pathogenesis will be from low grade to high grade, and dysplastic nodule to the poorly differentiated HCC. Gross types will be nodular type, massive type, and diffuse type, which will be involving the liver. Then we have a fibrolamellar variant and combined HCC with cholangiocarcinoma, paraneoplastic syndrome, which has most common hypocholesterolemia. Secondly, hypoglycemia, cutaneous being seborrheic keratosis. Imaging features with the investigation of choice is triple phase CT scan, which shows arterial enhancement, that is hyperdense in the arterial phase. We have to avoid FNAC. Tumor markers will be helpful like AFP in the follow-up and recurrence cases. Staging with the help of Okuda staging system, where we'll see tumor size, ascites, albumin, bilirubin, and this will help us in management. Stage 1 will be no of these above positive, stage 2 will be 1 or 2 positive, stage 3 will be 3 or 4 positive. Then we have the management. In the management, we have various modalities like resection, which will be curative, followed by liver transplantation in case where we have less reserve. Ablation technique, radiofrequency ablation, ethanol, cryoablation, microwave ablation, regional liver therapies, chemoembolization, chemoperfusion, internal radiation therapy, stereotactic radiosurgery, and intensity modulated radiation therapy, systemic chemotherapy, and multimodality approach. So this is all. We'll have a further discussion in detail regarding this topic, but this will be sufficient for writing a long case for the UG level MBBS and postgraduate level. If the question is, please explain about the risk factors, clinical features, and management of HCC for MS and DNB general surgery students. Thank you. Keep studying, keep growing. Please like, share, and subscribe. Thank you for watching. We'll see you in the next session. Thank you. And never give up, because great things take time.